Hi everyone, my name is Louise Ross and I'm here today with Professor Nick Zwar, who's from Bonn University and where he works as the Executive Dean. So Nick's here today to do a presentation on the new clinical practice guidelines from the ASCP. He has a background in medicine as a general practitioner and as a primary care teacher and researcher. He was previously the Dean of Wollongong University and a Professor of General Practice and Deputy Dean at the University of New South Wales. He's got extensive experience in the development of clinical practice guidelines, and the RACGP guidelines that were recently released on the 28th of January have had some significant updates. Nick's here. Nick chaired the expert advisory group for the development of these guidelines, and he's here today to talk about the changes to the guidelines, which include the addition of the 3A's model and recommendations around the role of nicotine-containing electronic cigarettes and vaping devices. Nick will provide an overview of the key changes in the process for developing the guidelines and the rationale behind these changes. I'm very pleased to welcome Nick here today to deliver this presentation on behalf of AS, Special Interest Group and APSAD. And so if you have any questions, feel free to use your toolbar at the bottom, the Q&A button, to type them in, and then we'll deal with any questions at the end of the presentation. So over to you, Nick. Thank you.
Thanks, Louise, and welcome everybody. As many of you would know, the RACGP has been involved in producing publication around supporting smoking cessation for quite a number of years. In fact, the very first edition was way back in 2004, and I was involved in that one as well. And that was really aimed at general practice specifically. But over the years, it became clear that there was a demand for a guide which was useful for a range of health professionals. And so since 2011, Supporting Smoking Cessation, a Guide for Health Professionals, has been produced. That was the first edition, and trying to be useful for people in a range of settings. Clearly general practice, but also in a range of other settings, including pharmacy, including in hospitals, in primary care settings, in community health, in specialist practice. So trying to provide something that would be useful to support health professionals who are interacting with people who smoke in a range of settings, and to provide evidence-based suggestions on how to go about helping people to stop smoking. So we did some minor updates in 2012 and 14, but then we were fortunate to get some funding from Vic Health and from the Commonwealth Department of Health to do a more extensive update and to actually look at some of the literature around some important questions, which Louise has alluded to some of those already. And so I'll look at those questions as we go along. And as has been already mentioned, we've also included a 3A sort of approach as well, to provide a structure which is briefer and also which can be used by a range of health professionals, because of course not everyone can prescribe smoking cessation pharmacotherapy. Okay, just moving along. So as I said, first published in 2011, then updated in 2012 and 14, and the new topics were around different ways of using pharmacotherapy, including combination nicotine replacement, a bit more about technology, and the controversial issue of nicotine-containing e-cigarettes, which certainly has generated quite a lot of interest and discussion. There were a range of people involved in the expert advisory group for the guideline, I was the chair of the group, as Louise has mentioned. So I'm a general practice background, and there are two other people from a GP background as well, but also public health background, respiratory medicine, pharmacology, addiction psychiatrist for the first time, which was a very useful perspective to have, nursing, tobacco treatment specialists, and people from the policy sort of area from both Commonwealth Health and from the funders. And we did have a whole range of other contributors as well, people who helped us along the way. And there was quite an extensive stakeholder consultation process where the draft guide was sent out to a range of interested groups, including APSAD, but nursing, Cancer Council, Consumer Health Forum, National Heart Foundation, various public health ministries around the country, psychiatrists, physicians, Stroke Foundation, the list goes on. So, and we had a lot of feedback actually from different groups and quite also extensive feedback from people who had particular interests and skills in supporting smoking cessation in Aboriginal and Torres Strait Islander people. So that was another focus to try to make sure we got input and feedback around the needs of Aboriginal and Torres Strait Islander Australians. The college commissioned the Joanna Briggs Institute to do some evidence reviews around key questions, which I'll come to those questions in a moment. And that was really helpful because it enabled us to do some up-to-date literature work and a meta-analysis where the JBI team, using our questions or based on our questions, did a review and presented the evidence in tables for us to look at. And we used a structure called the grade process, which some of you will be familiar with. It's the grading of recommendations, assessment and development and evaluation framework. And that is a now fairly commonly used process for rating the strength of the evidence and the certainty of that evidence and the strength of the recommendation that you might make based on that evidence. It's got the quality or certainty of the evidence can be high, moderate, low, or very low, and the strength of the recommendation can be strong or weak or conditional. So it is quite a complex process, and a lot of work goes into it, but I think it tries to give a more complete view about what not only the strength of the literature and the certainty of the evidence and the quality of the evidence, but also how strong or otherwise recommendation would be arising from that evidence. So that's by way of background. So what is, So what is grade? I think I've covered that largely. A systematic and transparent approach to looking at quality, certainty of the evidence, and move from the evidence to a recommendation. So the benefits, as I've said, are being rigorous around why you make recommendations, and it does preference RCT, randomised control trial or meta-analyses, and it does use that sort of hierarchical approach, but it does try to be a bit more nuanced about that, and as I said, give a framework for going from evidence to recommendation. So as I said, high, moderate, low, or very low is the quality or certainty of the evidence, and that's whether you really think you know what your estimate of effect is and how important that effect is as well. And then the strength of the recommendation, strong, weak, or conditional. And it's interesting in grade, one of the things that you're asked to do and to think about is, well, of the outcomes you have in mind, which are the ones that are really important? Well, clearly in our looking at the literature, smoking cessation was a really important outcome, clearly, and smoking cessation at a reasonable length of follow-up got more attention than, say, a very short-term follow-up. And when we're, say, for example, looking at issues to do with this smoking cessation in pregnancy, clearly whether a woman was able to stop smoking was a really important outcome, as were the outcomes for the pregnancy and the neonate. So things like, whether there was a preterm birth, whether there was low birth weight, whether there's a neonatal death, clearly they're very important outcomes when you're thinking about what matters in helping women in pregnancy to stop, and the outcome for that woman and for her child. Okay, so what was new? Well, we looked through the recommendations from the previous edition, and some were really kind of standard practice, and we didn't think we needed to continue those through. There was a small number where the evidence didn't really support them anymore, or more commonly, they were superseded by a new recommendation. And then we looked at some new recommendations around combinations and dosage of pharmacotherapies, relapse prevention, use of NRT during pregnancy, and, as I said earlier, about the role of nicotine-containing e-cigarettes as a cessation aid. We were focusing on cessation, so that was the particular context in which we were interested in nicotine-containing e-cigarettes, rather than a broader use of e-cigarettes, nicotine-containing e-cigarettes as a harm reduction strategy. But we'll come back.
Nick, I just want to interrupt. Apparently the slides aren't, they're not moving through.
Oh no, okay.
Yeah.
Oh, they're moving through on my screen. Wonder why that is.
What slide are you up to?
I'm up to slide, what's new in the second edition. Okay. Try something else here. See if that's
yeah, so we're still on the first one.
Ah, how annoying. Okay. Okay, what can I do? I'll try.
Maybe just check the, is it still, well, it's still sharing, I'm not sure.
So nothing happens when I click on my screen, obviously.
So you're able to click through on your screen, but it's not, yeah, it's not coming through on ours, no.
Okay.
I'm not sure why.
Weird. It's very... I'll try something different.
Sorry. So Liz. There you go. It's come up now.
Okay.
Yep. So yeah, we're on the grading slide. That's all good. Okay. Thanks.
Sorry about that.
No worries.
Glad someone pointed it out. I should have realised earlier because yeah. So we talked about this. What is grade? I think we talked about a lot of that was preliminary. So it probably doesn't matter that much. Let me click through to where we're up to. We talked about grade, talked about strength of recommendations, and then what's new in the second edition. Okay, so these were the recommendations that were removed, and of course assessment of readiness to quit and the trans-theoretical model of change has been something there's been a lot of debate about, and as many people would know, it doesn't seem that the stages of change is terribly predictive of people's success, and that when people make an attempt to quit, even if they haven't gone through the stage of change sort of process, that their likelihood of success is no different. So it's getting across the point that everybody who smokes should be offered assistance to quit, and it's not only those who express interest at the time where that may be beneficial. So we removed the assessments of readiness to quit as a process that was recommended. Having said that, I think as a clinician, it can be useful to get an idea of how your particular client or patient is thinking about smoking at that point in their lives, because even though we know that may change quite rapidly, it still can help you to target or tailor your advice in a way that makes it, I guess, fit more with the interests of the person at the time. And so I think as a tool in clinical practice, targeting your advice to the level of interest is useful, but it is very important that everybody is offered support to quit at every possible encounter. Recommendation 7 was about nicotine monotherapy, recommended to all dependent smokers. Well, because combination NRT is more effective, we removed that recommendation, replaced it around offering combination NRT as the preferred initial nicotine replacement therapy option. We just moved the evidence about hypnotherapy. We changed our recommendation slightly about pregnancy, and I'll come to that in a little while. Standard practice to provide smoking cessation advice as a major focus in management of people with smoking-related disease. That's standard practice. And people attempting to quit advice to ban or restrict smoking in their homes. Again, we thought, well, that's standard practice. We didn't need a specific recommendation around that. Okay. So these were our new questions, our Pico, patient intervention, comparator and outcome questions. So is combination nicotine therapy, i.e. patch in a rapid-acting oral form, more effective than patch alone? And if so, is that for everybody or just more nicotine dependent? The second part of that proved impossible to answer, but we did look at the first part of that. Is the combination of varenicline and NRT more effective than varenicline alone? Because that has been something that's been talked about and done by a range of clinicians around the world to, if someone's being prescribed varenicline, to suggest that they take NRT, usually in the form of the patch as well, at least initially. So we wanted to look at that question. Relapse reduction by longer courses of NRT or a second course of NRT. Again, with varenicline, does a longer course or a second course reduce relapse? The thorny question of use of NRT in pregnancy, is it safe and is it effective? And are nicotine-containing e-cigarettes effective aids for smoking cessation? So with each of those questions, we commissioned the JBI, Joanna Briggs Institute, to do a review. So we'd have up-to-date data or evidence on those questions. And I'll just run through each of them now about what data we found from the systematic reviews and then what conclusions we reached. So the first one was about combination NRT. So this was something that's been talked about for a while, and we had said something about it in the previous edition. But the review by JBI found a large number of studies, 12 randomised trials with over 6,000 participants, and not a very strong effect size, 1.28, but a benefit. And given the amount of evidence, we thought it was moderately strong evidence of benefit. And it's a small improvement in smoking cessation rates, but certainly not a trivial one. So we thought that it was made good sense and was evidence-based to suggest that nicotine combination was more effective than monotherapy. And that if you're initiating someone on NRT, that combination therapy would be the evidence-based choice because of its greater effectiveness. And there wasn't evidence of greater adverse effects in the studies that JBI looked at. So that was reassuring that, that it wasn't going to create more adverse effects, but did have evidence of improved quitting rates from using combination NRT. So the next one was around what about longer courses of NRT? Did they make a difference? So there's been a number of randomised trials about just long-term NRT, up to 52 weeks versus standard NRT. And those two randomised trials, interestingly, didn't show any difference in quit rates. But the use of NRT as a relapse prevention strategy, so if you have people who are quit at the end of a standard, say, 8-week course, and then you randomise people to a further course or not, the people that get the further course had some evidence of benefit. You can see the relative effect was 2.17, but the confidence intervals were quite wide. So we weren't sure it was a very strong evidence here. Again, there wasn't any sign of increased adverse effects. But so this is a fairly cautious recommendation that a clinician could consider an additional course of NRT to reduce relapse at the end of a standard course, and a conditional recommendation, but low certainty, given that the evidence was wasn't enough randomised trials to be very sure of that effect. And it wasn't it was a reasonable size effect, but you can see that the confidence intervals went from 0.85 to 2.17, so a fair bit of uncertainty about where the true effect lies. Next thing was about women in pregnancy, and my strong point here that the group felt that the evidence was that the preferred way of quitting in pregnancy was with a non-pharmacological approach, given the uncertainties around the safety and the effectiveness of pharmacotherapies in pregnancy. And there's some evidence on rewards and things that would encourage women to try that. And not many health systems support that. But in fact, there's pretty good evidence that some sort of incentive and reward for women is helpful to increasing quit rates. And of course, preferably before women fall pregnant would be the ideal time, but in early pregnancy if that's not the case. And then the important to continue the support after the birth of the child, because relapse is common after delivery. So we looked at NRT. We didn't look at varenicline and bupropion, though I know there's been a study published fairly recently from UNSW looking at data on use of medicines in pregnancy, smoking cessation medicines in pregnancy, which didn't show any evidence of harms from varenicline, but there's no license. I mean, it's not licensed in pregnancy, and there's not randomised trials of varenicline in pregnancy. So that, is an issue, and we didn't look at that. But we looked at NRT, and as you would know, there's been concerns about the theoretical risks of exposure of the fetus to nicotine in utero, and whether that would have an impact on neurological development. And there's some animal studies to suggest it may have adverse effects, but not actually human evidence to support that. So JBI looked at examine outcome of smoking cessation in later pregnancy, so during the course of the pregnancy. And there were 8 randomised trials involving just over 2,000 participants of nicotine replacement therapy compared to no NRT. Both groups got some behavioural support. There's a whole range of issues with the studies, and sometimes that the women didn't stay on NRT for very long periods, and some people believe the doses were too low. But having said all that, there was some evidence of benefit despite those caveats, and importantly, there was no evidence of increase in adverse effects, either pregnancy-related problems or problems in the neonate or infant of women who used NRT versus didn't use NRT. And in fact, when you looked at all of those measures of adverse effects, they were actually lower in the NRT groups across those studies, though the rates were small, so you wouldn't want to make too much of that. And so there were some evidence of improved cessation outcomes, though not strong, and again, a conditional recommendation and low certainty. But I think it's saying that if a woman has not been able to quit using behavioural support, that clinicians could recommend NRT, but with that discussion around the need for monitoring and the understanding that the evidence of benefit is not strong, but of course, if you do help women to stop smoking, the improvements in outcome for both the mother and the child are really important. Next one was about varenicline and whether adding NRT to a course of varenicline in outcomes. And there were some studies here. So there were 2 trials that JBI found with 787 participants who met the entry criteria, which included biochemically confirmed cessation. And the effect size was quite substantial, 1.62. And you can see the confidence intervals 1.18 to 2.23. So the EAG actually thought there was moderate evidence here, and there's a small but worthwhile improvement in smoking cessation for people taking NRT along with varenicline and NRT together compared to NRT on its own. Now, it's not common practice as yet to do this, and it'll be interesting to see what happens with that. And of course, on the PBS, those 2 are not subsidised at the same time. But I think this does provide some evidence that, a discussion with your patient, how I would see it is you're prescribing varenicline for them, you've decided that's a reasonable choice, to have a discussion about whether to combine that with NRT for a period of time on the basis that may improve their chances of success. I think this will continue to evolve, this evidence, and will be, in a year or two's time, there'll probably be other studies that might add to the body of evidence. But even now, it appears to be a worthwhile kind of level of effect. Interestingly, when you look at the combination of NRT with bupropion, which because they did as well, we didn't find any evidence of additive effect. So that was not shown to be effective, adding NRT to sustained release bupropion. There wasn't a lot of studies there, but that didn't show up as having a benefit. Now, nicotine-containing e-cigarettes. Okay, so now Now, I guess, preface this with a few remarks. So, as I said earlier, we were really focusing in on nicotine-containing e-cigarettes for the purpose of supporting smoking cessation. And that is in the context where nowhere in the world, to my knowledge, has a manufacturer of e-cigarettes applied to a therapeutic goods administration or equivalent body for a license for that product as a smoking cessation aid. So no e-cigarette product has been through a full regulatory assessment as a medicine. You know, there are nicotine-containing e-cigarettes in Europe, for example, which have been looked at by the European Medicines Association in terms of what they contain, but it's a different level of data, evidence, and safety data as well that's required for a therapeutic goods type application. And that leaves clinicians in a difficult position because we don't exactly know what the nicotine-containing e-cigarettes that we might recommend actually deliver in terms of vapours. And of course, you know, the nicotine e-liquid is illegal unless there's a prescription. And I think in Northern Territory, even with a prescription, it's not legal. So we have a complicated regulatory environment where these are not available as medicines, but there may be people who would benefit from using them to try to quit, who've not been able to succeed in quitting using the approved medicines. So there was a lot of debate and discussion within the group around that, given that context. But we asked the JBI to look at the evidence, and they looked at the question about whether nicotine-containing e-cigarettes were more effective than standard NRT in producing cessation. And there are a number of trials around that, and some of you would be aware of those, including in the one from the UK that was done in the context of the UK smoking cessation services. And so the amount of evidence has been accumulating. So in total, there were 3 randomised trials which JBI identified with 1,498 participants. And the relative effect of nicotine-containing e-cigarettes versus standard nicotine replacement therapy, either patch alone or in the HAJEC study, it was combination NRT, was still a benefit favouring nicotine-containing e-cigarettes, relative risk of 1.69 and confidence intervals of 1.26 to 2.28. Now the follow-up varied. Some were only a very short term, up to 8 weeks, at 8 weeks, and some were 52 weeks. And there's not a lot of studies. But having said all that, we came to the view that that was a evidence that there is or can be benefit, but with all those caveats about the lack of certainty about the products. So hence this rather long recommendation, which makes the point that these are not first-line therapy. First-line therapy would be one of the approved medicines which we've been talking about, NRT or varenicline or bupropion sustained release. And there's a lot more data there for safety. We really don't know about long-term safety of e-cigarette products. And there are concerns about short-term safety as well, though when we looked at the data from the randomised trials, we didn't see anything that was too worrying in the short term, in the follow-up, in terms of those randomised trials. So then it's the recommendation that if people have tried the approved pharmacotherapies but not succeeded and were motivated to quit and have brought up the issue of e-cigarettes, then it may be a reasonable intervention to recommend. but you need to go through, if you're the clinician involved, in an evidence-informed decision-making process that talked about the lack of certainty around the product, that we don't know about the long-term health effects, about the legalities, that really short-term use is the thing that's recommended, and there is a reasonable amount of data that suggests that longer-term use of e-cigarettes is more likely to occur than other therapeutic nicotine and the dual use, so continuing to smoke tobacco while using nicotine-containing e-cigarettes is not recommended, needs to be avoided. So conditional recommendation and low certainty, given the smallish number of trials and the fairly wide confidence interval. So, as I said, the effect was not a small effect. 1.69 is a reasonable size effect, but the lack of not any longer term studies. And this is clearly the recommendations that received the most attention in the subsequent commentary around the guideline. Some people have thought, given the lack of an approved product or tested product by therapeutic goods, that we should have held off and not said this. But as, I guess, clinicians, which many people on the line will be, you've got a smoker in front of you who you'd like to help to quit, and we don't know if or when a medicine, a nicotine-containing e-cigarette, will be available as a medicine, and we have an issue about someone we'd like to help here and now. So in that context, we have made this recommendation. Okay. So I think I've said all that. That's the evidence behind that recommendation. As I said, the evidence certainty was rated as low, but there was a moderate improvement in outcomes for smoking cessation for the nicotine-containing e-cigarettes versus therapeutic NRT. And as I said, sometimes it was comparison to NRT monotherapy, but in one study it was comparison to people that were using combination NRT, or most were using combination NRT. And we didn't look at the issue of e-cigarettes, nicotine-containing e-cigarettes versus placebo, because it seemed to us, well, that's not really such an important comparison to make. It's, are they better than standard NRT or NRT? And that was the question that we focused on. There's information, updated information on high prevalence groups, Aboriginal and Torres Strait Islander peoples. I mean, there's been some success in reducing smoking in Indigenous Australians, but the target of halving smoking cessation in Aboriginal and Torres Strait Islander people by 2018 was not met, as many of you would know, so there's a lot more work to do there. And in rural, and particularly rural or remote Indigenous communities, the rates of smoking are shockingly high. Culturally and linguistically diverse groups, I think generally there's been an improvement, but there's still some higher rate prevalence groups in society. We've talked about pregnant and breastfeeding women, such an important group to quit, both for the woman and for her child. Adolescents and young people, clearly a group where uptake of tobacco use is an issue, and where if we can help people either not to start smoking or to quit, then that's very important. There are higher rates amongst lesbian, gay, bisexual, transgender and intersex people, so we've put some information about that in the guide. People with mental illness remains a huge issue, because smoking rates are about twice as high in people with depression and 3 times as high or more in people with psychotic illnesses. So that's a group that really, there's a lot of work remains to be done. People in prison continue to have high rates. Smoking-related diseases, clearly important, and helping people who are hospitalised to make an attempt to quit, and then supporting after come after discharge from hospital, because if it's not supported afterwards, it's less likely to be successful in supporting a person to quit long term. I'm just about finished. Just a few words about the Ask, Advise, Help framework. This is Quit Victoria, and they kindly made this available for us to add to the guide. And it's, I think, trying to serve a number of purposes here. One is for clinicians who are really under time pressure and do not feel they have the opportunity to provide comprehensive support within their own practice, then advising in a non-confrontational way that quitting would be good for your health, advising about behavioural intervention and smoking cessation pharmacotherapy as the evidence-based way that's had the best success rate, and then offering referral either to the quit line or another form of support as an option for behavioural support and a more comprehensive, longer-term intervention to assist those people. So this is available for a range of health professionals. You don't have to be able to prescribe a medicine to use this approach. So it could be used by a whole range of people who are not necessarily prescribed as smoking cessation pharmacotherapy, and it can be used by those who can prescribe when they don't have capacity to offer the support at that time. Be interesting to see how this goes. I hope it will be helpful. And then this is the Pharmacotherapy Algorithm, which is not that different, except given that, as I said, nicotine replacement therapy combination of varenicline appears to be, from the Cochrane reviews, more effective than bupropion. We've suggested there the choices as the most effective evidence-based and approved pharmacotherapy, but bupropion is a reasonable option with people not suitable for those. And then the follow-up is not that different from the previous editions. Right, there we are. That's about all I had to say. So we'll open it up for any questions or discussion.
Great, thanks, Nick. If anyone has any questions, if you could type those in and then we'll respond to them. I've got a few questions if others don't. I'll just have a look. It's coming through. Just while I'll see if any come through, I'll ask one of the questions I had. When you were looking at the effectiveness of electronic cigarettes versus nicotine replacement therapy, did you also have a look at it compared to varenicline? Were there studies around that? Did you explore that question?
We would have liked to, but we didn't find sufficient studies to look at that question. I'm sure that will come because I know that those studies are occurring, but there's kind of often a lag time between studies, and when they're finally reported in the literature. So even though studies are going on from talking to colleagues, when looking, we couldn't find enough actually published studies to look at that question.
Yeah, okay, great. I can't see any questions come through, so I'll keep going. When you say, when in the guidelines, when it says the use of e-cigarettes in the short term, is that qualified in terms of how do we define short term?
Yeah, we didn't put a figure on it, but in most of the studies, people have tended to use them, for about 8 weeks. And some of the studies just look at the outcome at that point. So, a bit like, of course, nicotine replacement therapy. But as I said, there has been a tendency in the Hayek studies, for example, that people would continue to use their nicotine-containing e-cigarettes for longer